Hello, we are 3 nursing students from Virginia Highlands Community College. We have been assigned an assignment this semester to teach you all in our community about cancer. We chose the pediatric cancer because we have a friend who has had a daughter who is a cancer survivor, and I have 3 young children myself, so it's just something that we all would be something that we could all get together with. We'd love for you guys to give us some feedback at the end. If you have any questions, just let us know. My name's Kayla Rowe. We have Nicole Lester. If you can see her, she'll give you a wave.
Hey.
And then we have Amy Greer.
Hey.
All right, we're going to go ahead and get started. Just bear with us. So throughout this teaching, you're going to learn some things, some objectives like understanding pediatric cancer, how cancer affects each pediatric age group, risk factors that contribute to pediatric cancer, the screening, the diagnostic testings, and treatment, and identifying cancers associated with pediatrics. Go to the next slide. Some people would say, what is pediatric cancer? Pediatric cancer is a broad term describing cancers that occur between birth and 18 years of age. Pediatric cancers are considered rare. They often differ from adult cancers. You don't really hear of breast cancer, liver cancer, things like that in younger children. You do of liver, but not of breast and lung cancer and things like that. Some ways that they're different, they grow and spread differently, they're treated differently, and they respond to treatment a lot differently. Some institutions, such as St. Jude's, actually recognizes pediatrics until 20 years of age. Rare as it is, it's estimated that 43 children in the United States will be diagnosed every day. That's in the U.S., that's actually 15,780 children ages 0 to 19 every year. It is actually the #1 cause of death of children in the U.S., and it says that in 2017, it's estimated that cancer took away 11.5 million years of healthy life from children globally. That's something that really sinks in and hits hard, I believe. It's those statistics they're hard to swallow sometimes. Cancers that affect children are often different from the types that affect adults. I've already said that. They're not strongly linked to lifestyle or environmental risks like a lot of adult cancers are. We know that if you smoke, you are more at risk for lung cancer, but we can't really tie anything back to pediatric cancer besides a lot of your DNA and what you carry through. So let's go to the next slide, slide 4.
Kayla, can I interrupt you for just 1 second and let our participants know that they can mute their microphones on the Zoom call by going to the bottom of their screen, because it gets a little
their feedback coming through,
fuzzy coming through. Yes.
Am I going too fast for you guys? You ready? Are you ready, Amy? Can you guys hear me?
I muted myself and couldn't unmute. Sorry. Yes.
Okay. Just to make sure. Okay. All right. So for the sake of this assignment, I think I told you guys earlier that we divided the age groups up a little differently into 3 different sections. I did 0 to 5 years because I have children around that age group. Amy did 6 to 12 years, and Nicole took 12 to 18 years. So that's the 3 groups that we have kind of divided it into, and that's why it shows that on the slideshow. We'll go to the next slide. So here in this picture is a picture of Cheyenne, and Amy may know more about this photo that she can tell you a little bit more, but The basic idea is that the average age of children diagnosed is 6 years old. The most cause of pediatric cancers are unknown. Children can be born with the genetic predisposition for cancer. In some cases, it's a fluke, something that causes genes to mutate. In others, parents can pass on the risk. Cancer-causing environmental factors such as cigarette smoke, asbestos, and ultraviolet radiations from the sun, those are basically the only thing that we can link back into possibly causing some kind of childhood cancer other than your just your genes. Okay. Again, like I said, slide 6 says that what causes children to get cancer is really unknown besides gene mutations and the environment. Children can be born with a genetic predisposition for cancer. In some cases, it's a fluke, just like I just said. So we'll go to the next one. I could sit and tell you about several different kinds of cancers. There's many different types, but we kind of broke it down into leukemias and lymphomas, brain tumors, and solid tumors. Leukemias are cancers of the white blood cells. It includes, but not limited to, acute myeloid leukemia, acute lymphoblastic leukemia. Lymphomas are cancers that start within the lymphatic system. This includes Hodgkin's and non-Hodgkin's lymphomas. Brain tumors, ATRT, is typically known as atypical teratoid rhabdoid tumor. Medulloblastoma, I hope I'm saying that right. I may be butchering it all to pieces. And then some solid tumors is what we have in the gray. They are like Ewing sarcoma. It's a cancerous tumor that grows in the bones or in the tissue around the bones in the soft tissue. Neuroblastoma is tumors that generally develop in the adrenal glands and can spread to other areas, including the chest, the spine, or the spinal cord regions, and the abdomen. Retinoblastoma is a very rare cancer of the retina. Osteosarcoma is the most common type of bone cancer in children and in teens. Wilms tumor is a solid cancerous tumor of the kidney that arises from immature kidney cells. We'll go down to the next slide, slide 8. This just kind of says meet the team. It just kind of tells you who all is part of a team. When I first thought if a child was diagnosed with cancer, he or she would see an oncologist, but I didn't realize how many people played a part in that. So your first tier is like your PCP, your primary care physician. That's normally where the diagnosis or symptoms are recognized. Then you have the pediatric medical oncologist. You have a radiation oncologist. You have a pediatric nurse specialist who is, your nurse who is there with the patient through and through. Your hematologist, your psychologist, the pediatric surgical subspecialist, and a rehab specialist. Sometimes that's not needed and sometimes it is, but I feel like the way I understand it is this team is the first team that meets when a child is diagnosed, and then they decide who they need and who they don't need, and they kind of branch off. Okay, we'll go to slide 9. Next is diagnostic tools that are just used to diagnose pediatric cancer. So you have CT, CAT scans. They're also known as computed tomography scans. They use special X-ray equipment to create a 3D picture of the inside of the child's body. They can show the presence of a tumor and can also be used to show how a tumor is responding to treatment. I think it is amazing the technology that we have today that can help us see inside of a body. It amazes me. Next, there is MRI. It uses magnetic fields to make detailed pictures of the organ structure and the blood flow in and out of them. It can show the location and size of a tumor. It can help determine if it is safe to remove with surgery or not. And it shows sometimes whether a brain tumor is cancerous or not. MRIs is also helpful to doctors when they plan the radiation therapy. Okay, next is a PET scan. These are 2 parts testing. First, the child receives an IV with a small amount of radioactive sugar called a tracer. An hour later, the child is taken through a tunnel-shaped PET scanner for imaging. It shows how the organs such as the bones, brain, kidneys, and liver are working, and a computer turns the signal from the tracer into 3D pictures. All right, next we'll go to the next slide, slide 13. This is starting our treatment side of things, and Amy will take over from here.
All right, guys. So I'll start with treatment. Obviously, the ultimate goal of treatment is to eradicate the cancer. So the treatments that we're going to talk about today are not limited to just these, of course. They're always evolving and developing new treatments and clinical trials, but these are the main ones that we want to highlight today. So I'll start with chemotherapy, which is a use of powerful medicines to kill cancer cells or stop them from growing altogether and making more. Chemo is injected into the bloodstream through a large central line or port that's placed in the child's chest to give direct access so that the medicine can travel throughout the body. Radiation, of course, is the use of high energy X-rays, other types of radiation to kill cancer cells and or to stop them from growing. So the ultimate goal here is the same as the chemotherapy. There are two types of radiation, external and internal. The external uses machines outside the body to deliver the X-ray dose, as you can see pictured there. And internal radiation uses needles, seeds, wires, or tubes to deliver the radiation directly into or close to the cancer. Surgery is obviously used to remove the tumors. Can be done before or after chemotherapy. Often the doctors will use the chemotherapy to shrink the tumor to make it easily accessible for the surgeon. Bone marrow transplants, these are complicated. Often high-risk childhood cancers are subject to these. So they also call them stem cell transplants. And the goal of those are to replace damaged and or destroyed bone marrow cells with healthy ones. And the reason they also call it stem cell transplants is that it can be taken from other blood sources, like circulating blood from the peripherals or umbilical cord blood. Again, they use those in high-risk cases of leukemias, lymphomas, solid tumors, and other bone marrow deficiencies. And forgive me, I'm stuttering over my words. So cancers associated with pediatrics, Kayla touched on those earlier when we broke them down into the tiers. We're going to highlight some a little more in depth and detail. Neuroblastoma generally develop in the adrenal glands where neuroblasts are commonly found. It's the most common tumor found in infants and accounts for 50% of all cancers in infants. So the symptoms include a hard, painless mass in the neck, stomach pain, feeling irritable, decreased appetite, leg weakness. Treatments include chemotherapy, surgery, radiation, and in extreme cases, stem cell transplants, as we discussed earlier. This is little Gideon Purchase. He was diagnosed at stage 4 high-risk neuroblastoma. He was just 7 months at diagnosis. Reed Lawson, she had ganglion neuroblastoma at age 3.5. She's still undergoing treatment at St. Jude. Rhabdomyosarcoma, cancerous tumor that affects soft tissues such as muscles. There are two types, embryonal, which is often seen in children under age 5, and alveolar affects all age groups. Most common type of soft tissue sarcoma in children. Symptoms include a lump or swelling that does not go away, bleeding in the nose, vagina, or rectum, constipation, bulging eyes, headaches, and treatment includes surgery, chemotherapy, and radiation. This is Grayson Walworth. He was diagnosed with rhabdomyosarcoma at age 3.5. Acute lymphoblastic leukemia, is also known as ALL, affects the white blood cells. Those white blood cells fight infection and help protect the body against disease. and it affects about 3,000 people younger than age 20 in the United States. Symptoms include frequent ear infections and fever, easy bruising, bleeding that's hard to stop, flat, dark red skin spots or pataki due to bleeding under the skin, pain in the bones or joints, lumps in the neck, underarm, stomach, or groin, weakness, fatigue, paleness, loss of appetite, and shortness of breath. Treatment includes chemotherapy, stem cell therapy, radiation, and targeted therapy. This is Gavin Brewer. He was diagnosed with ALL at age 2. Acute myeloid leukemia, AML, is a white blood cell cancer that are abnormal white blood cells that do not become healthy cells. It's more common in adults than children, which is surprising. Seen more often in children who are exposed in large amounts of radiation and some kinds of chemicals. Symptoms include fever and infection, easy bruising and bleeding, frequent nosebleeds and hard to stop bleeding, pain in bones or joints, swollen glands, poor appetite, and treatment includes chemotherapy, stem cell therapy, and immunotherapy. This is Kingston Banker. He was diagnosed with AML at 7 years old. Don't you just love to see that transformation though? Like from being so sick and taking treatment to a vibrant, healthy young boy. It just blows my mind. Ewing sarcoma, a cancerous tumor that grows in the bones or in tissues around the bones. About half of all Ewing sarcoma tumors occur in adolescents between ages 10 and 20. My takeaway from that is that, it's in that spell of kids growing and their bones expanding. Ewing sarcoma often goes undiagnosed or misdiagnosed for quite some time because of kids playing sports and being active. And again, being in that growth process, they just don't recognize these symptoms that include swelling and soreness around the tumor area, again mistaken for sports injuries, a low fever that at first may seem to be caused by an infection, bone pain worsens during exercise or at night, limping which is caused by a tumor on the leg bone. Treatment includes chemotherapy, surgery, and radiation. This is Mac Ward. He was diagnosed with Ewing sarcoma at age 5. And unfortunately, he's lost his right leg due to that, but it hasn't stopped him. He still plays basketball and tries to play football to the best of his ability. Miss Emma Burchard was diagnosed with Ewing sarcoma at age 12. Unfortunately, she completed her battle a couple of years ago when she was just 14 years old. Brain tumors. Some examples of brain tumors in pediatric patients would be diagnosed with glioma or ganglioglioma, germ cell tumors, meningioma, optic pathway tumor, and pineoblastoma. They have some weird names, obviously. Symptoms include headache, increasing severity over time, nausea, vomiting, impaired vision, confusion, memory loss, and seizures. Treatment includes, but not limited to, surgery, radiation, proton beam therapy, chemotherapy, targeted drug trials, clinical trials, and rehabilitation after treatment. Again, all these treatments are being revised and just studied over time, and it's amazing what they're coming up with each and every day. Wilms tumor is a solid cancerous tumor of the kidney that arises from immature kidney cells. It's the fourth most common type of childhood cancer, and it affects about 1 in every 10,000 children. Symptoms include, but not limited to, fever, nausea, loss of appetite, blood in the urine, constipation, high blood pressure or hypertension, or shortness of breath. Treatment includes surgery, chemotherapy, and radiation. And this is Cheyenne. She was diagnosed with Wilms tumor at age 7. And I'm going to pass it on to Nicole for the next teaching, and she's going to do our adolescents and teens.
Okay, so like Amy said, we're moving on to cancer in adolescents and teens. This is going to cover the age group of 13 to 20 years old. We do see a few differences in cancer with adolescents and teens that we do in childhood cancers. So we'll go ahead and move on to the next slide. So the most common cancers that we do see in teens is going to be blood cancers like leukemia and lymphoma, thyroid cancer, brain tumors, bone cancer, osteosarcoma was one of those that Kayla mentioned earlier, as well as cervical cancer, skin cancer, and some soft tissue sarcoma. So some statistics we found on teenage cancer was that 33% of the patients at St. Jude are teenagers that are battling cancer. More than 5,000 teens ages 15 to 19 in the U.S. are diagnosed with cancer every year. Teen cancer patients often face different issues and different cancers than the younger patients would. The most common cancers among teens include Hodgkin lymphoma and thyroid carcinoma. And this is a picture that one of Amy's friends was nice enough to share of Miranda McLaughlin, and she was diagnosed with Hodgkin's lymphoma at 13 years old. We'll move on to the next slide. So this is some of the things that teens often face, the special challenges related to their diagnosis and treatment. These will include late diagnosis. So as people get older, they tend to think that they're healthier. So they don't always see a doctor as often as a child or an older person. They're also twice as likely not to have health insurance compared to other age groups. For these reasons, their cancers are often more advanced at the time of diagnosis, and that does make it harder to treat, unfortunately. We also see with teens a non-adherence in treatment. So teens and young adults have more control over their cancer treatments than young children, but they also are more likely not to stick to their treatment plan. For example, if we have a teen who's suffering from emotional issues, they might forget to take their medication on schedule. Or a young adult who no longer lives with their parents might have difficult arranging a ride to their appointments or treatments. Ultimately, when patients stray away from their treatment plan, the treatment is less likely to work. There are also lower enrollment in clinical trials with teenagers. Clinical trials are an essential part of cancer research. And for patients who have few other treatment options, they can be their very best hope for a cure. Teens and young adults are less likely to take part in clinical trials than younger and older patients with a similar diagnosis. So we will move on to the next slide. And while most causes of pediatric cancer are unknown, and if your child does develop cancer, there is absolutely nothing you or your child could have done to prevent that. But we do, with teenagers, like adults, have some risk factors that can be considered. So we think about tanning beds, exposure to ultraviolet UV light could be a risk factor, as well as consumption of alcoholic beverages, tobacco, and that can be e-cigarettes, regular cigarettes, vape, Juul, anything like that has been linked to a risk factor for cancer. Also, infection with the human immunodeficiency virus, which is HIV, and treatment with chemotherapy or radiation therapy for a childhood cancer does typically increase the risk of getting a second cancer like leukemia later on. And we're going to move on to the next slide. This is a picture of Addie Pratt. She was diagnosed with myeloid leukemia at age 14. And in the next slide, if you want to know what you can do to educate yourself and your teen involving pediatric cancer in that age group, it's important to know the signs and the symptoms of pediatric cancer in all age groups. And if you are seeing a multiple amount of those signs and symptoms, bring it to their doctor's attention. You also want to have an open and frank discussion with your teenagers about the preventable risk factors that we discussed. And on to the next slide. This is a picture that Amy shared, and this is a quote from Danny Thomas that says, "No child should die in the dawn of life." And on to the next slide. So that actually completes our presentation. If you need any more information, you can visit stjude.org, cancer.org, or alexslemonade.org. Those are some really good resources for you to learn more that you may not have learned in our brief presentation. So at this time, we just want to kind of open it up for any questions you all might have. We can just, ask questions, have a discussion. So if there's anything you all want to know, feel free to ask us.
Okay, I have a question. I'm Amy's mom. Where you said that if they have cancer in childhood, that it's likely for them to develop another cancer later on in life. How do you know the statistics of how often that would occur?
The research that I did on it, it showed that it was very rare. It depends on a lot of like the treatment that the child went through, as well as um, the genes they have and things like that. It is very similar to the first diagnosis of childhood cancer. Their genes have a lot to do with it. It is a risk factor that has to be listed, but it was down there lower on the list with a lower risk factor than some of the others.
Okay, thank you.
I'll take you up and follow that up with just that. Anytime you have cancer in any age group and you're taking chemotherapy, that's a toxin, and you're pumping that in your body. So the effects of that later on in life are still unknown, especially in pediatric cancers. They're still studying what effects that might have on them, and it's kind of like you're putting a Band-Aid on for now to cover something that might reveal itself later. It's just a risk that you have to take in that moment to get better. Anybody else have anything to add or any other questions? Any takeaways?
Y'all done a great job. I do have one question. Do you guys may have researched this a little bit in doing your presentation, but do you all know anything about the efficacy with cord blood and the results of that on pediatric cancer?
That's a really good question. Something that I would really like to look into myself. I know a lot of stem cell and bone marrow transplants are taken from a patient's sibling. They prefer it to be, within the family. And there are options online that you can go to register to be a donor to see if you would be a match for anybody else, like Match.com, or not Match.com, BeTheMatch.com. We don't want to do any of that today, but BeTheMatch.com, and you can they'll send you a swab, and you can swab the side of your cheek to potentially be a donor for someone else.
Thanks.
So I know that we kind of like read a PowerPoint to you guys, but do you feel like you learned some things that you may or may not have known? Was it somewhat educational? I know it's hard for us to read a PowerPoint and just listen to somebody talk. So we were hoping that it would kind of reach out to you guys with some of the photos and things like that. Did it help any of you guys with any of your questions or anything?
I think you guys, I'm like Kimberly, you guys done awesome. It's you educated me on things that, of course, I had no idea of. Seeing the children breaks your heart, number one, but then seeing how most are doing today it's amazing, and like you said, the technology is great, and of course, God gives them the knowledge to do that. So you've all done awesome.
Thanks. A lot of those pictures are local area children that have been diagnosed. I want to emphasize when they say rare, it's not near as rare as they make it sound. And I'll be the first to admit, whenever I would see the commercials come on the TV of the little bald-headed children, I would turn the channel. I would walk out of the room. I didn't want to acknowledge that kids too get cancer, and I think that's why the three of us wanted to shed some light on that. When they said we could do a cancer project, everybody automatically goes to breast cancer or the pink ribbons and all of those things that we already know and have already been brought to the forefront. And this hopefully will shed some light on that and bring a little bit of awareness too.
Yeah, this is something that I guess everybody has it in their heart to care about. But as I was reading through, some of the statistics that I read just shook me. Like one of the statistics said that every 3 minutes a child is diagnosed with cancer. Like as a mother, that just shakes my bones because it's something that we don't really think about until we see somebody who is close to us, or or we see the St. Jude commercial or something like that. But every 3 minutes is breathtaking.
Yeah, for sure.
Do you guys think that, like, I mean, as a mother, you sort of always have that in the back of your mind, but like Amy, I'm sure you can share your experience, or if you want to talk about it. But when you get that diagnosis, did you ever think of that prior to then? Like, this could be it, or is that just like a complete take back? Like, oh my gosh.
Well, yes and no. Cheyenne in particular, again, I want to emphasize that all the symptoms listed for any of those cancers that we just discussed are broad. They're, a kid has a fever every now and then. A kid is sore every now and then. It's nothing that, if you go home tonight and your kid don't feel good, don't automatically think that they have cancer. But in our instance with Cheyenne, when she was diagnosed, it had been an ongoing thing. And her biggest thing, and the one thing that got me to open my eyes that something was actually going on was, Mommy, my belly hurts. Mommy, my belly hurts. But I noticed that it was only at night. It was only at bedtime. So as a mom, you think, kid, go to sleep. You got school the next morning, So we'd put it off and put it off. But I would notice, of course, hindsight's 2020. I would pack her lunch and she would bring home 90% of it. So much so that I was going to ask the teacher, hey, is she talking too much? Is she not having time to eat? I would get off work at 6 o'clock and be home, and she'd be asleep on the couch. And then I noticed some weight loss that I thought, well, maybe she's just getting taller. She's thinning out. It's, just her growth process. And I remember very vividly being at work in the medical field, talking to my coworkers, explaining these symptoms and signs to her, and it just hit me like a ton of bricks of what it could potentially be. But then there's still no, it couldn't be. There's no way. So in speaking with the nurse, she said, you may want to go get her tested and see if she's just anemic. So I called the doctor, got her into the doctor, and it was no shock when they set me down. And anytime the doctor comes in with the nurse at the same time, it's never really good. And they set me down and took Cheyenne out of the room. And all I heard out of her mouth in that moment was tumor. And that was it. But thank goodness we had a wonderful team of doctors. Again, going back to that hierarchy that Kayla read to you, where it showed the primary care physician. That's where it started, was our local pediatrician who found it and had got us in contact with the next level. She found a wonderful oncologist at St. Jude. And then the things it just started falling into that order. We met with her primary oncologist, her radiation oncologist, and so on and so forth. I took that and ran. I'm sorry.
No, I enjoyed listening. Thanks for sharing.
My niece just finished her treatment after 2 years and 7 months for acute, what was it? It's all, but what's the middle word?
I think it's ALL, acute lymphoblastic leukemia.
Yep, that one.
Yep.
I didn't remember the middle name.
That's great.
Yeah. And they say it's rare. So there you go.
Is it really? Well, she was also a in vitro baby, and they said that in vitro babies have really high chances of getting cancer.
Yeah.
All
That's
right.
awesome. Thank you for sharing that.
Other questions for us? Yeah, thank you for sharing that. Anybody else? Sherry, I saw you get emotional there.
Anytime, you talk about Cheyenne, any child, like the Raleigh that y'all had a picture of, the little girl on the horse, she is my supervisor's granddaughter. So, I did not know how rare, I thought it was rare. I did not know that how common
Yeah.
it, and how many in this area has cancer until Cheyenne got it. And you just drop to your knees, you just, it's just unbelievable. And you don't think, you don't really think about it until it hits home, kind of thing.
Yeah.
I mean, you see the commercial, your heart breaks for those children, and you want to send your $19 to help. But when it is actually someone you can't do enough. You can't send enough for them to do research. Here, I don't want to send just $19. I want to send 50. Do more research to say, thank God you helped save my granddaughter. Please help save this person's granddaughter, grandson. And it's just, it's very emotional.
Yeah. I thought it was very rare too. And then we were going through the statistics and just seeing just the statistics, not even really a lot of the research. It blew my mind. Even knowing that Cheyenne had cancer and like little Riley Lawson, and there's so many others. Hoyt, I know his mom. You don't really realize how not rare, how it really is in our area, and it's right under our noses. So it's a different world, and I don't think a lot of people understand how common it really is.
Yeah, like the Chris Hope Foundation. Of course, Amy knows Chris Hope, and I've never got the pleasure to meet him. I have talked to him, Facebook-wise. Every time you see him put up that little picture of a yellow balloon, a child lost their battle, and it just breaks your heart. When you know that an adult has cancer, yes, it's hard, especially like my sister, my father, that hurts, but a child, it does something else to you.
Yeah.
I think there was a statistic of 11.5. Let me go back and find that because it's interesting to read. Let me see. Well, of course, I'm not going to be able to find it immediately. But yeah, so in 2017, it is estimated that cancer took away 11.5 million years of healthy life from children globally. So, I mean, when you think about it, like you said, not to underplay any other type of cancer or anything like that, but adult cancers, typically are older adults. You think about getting cancer. In children, they have so much life left to live, and it's just heartbreaking to see a kid literally fighting for their life. Again, that's why we wanted to do this and bring some awareness to it. And what shocks me that we didn't even mention in our presentation is that nationally, the budget for cancer research for pediatric cancer is 4%. 4%. That's 4 pennies out of every dollar that our kids get for research. I mean, when you think about it and the years lost compared to that of adult cancers, you would think that they might get a little bit more funding than they do. But so I guess it starts with us, and it starts with awareness and bringing that to the forefront. So I thank you guys so much for participating in this. And I hate so bad we didn't get to present it to a larger audience in person. And maybe one day we'll get to do that.
Well, once again, y'all did great. Very, very informative. I mean, it really was.
Thank you.
Yeah, thank you all, and we definitely appreciate your all's participation as well. It's been really great conversating with you.
It's been great listening and learning, you know.
Well, we have enjoyed you guys. Amy, I was just thinking back about the statistic that you said, and one of them that we actually forgot to put on my side was globally, it says there are 300,000 children diagnosed each year. That is mind-blowing. Like, I don't even know what to say to that. It's so all we can do is pray about it and just hope that we find more research to do and more answers, because there are so many children out here who are losing their lives to a nasty cause.
Yeah. But thank you all again for your time. I know it's about dinner time, and y'all just stopped in the middle of your day to do this, and I can't thank you enough.
Thanks for the invite.
Yeah. Do you guys have any more questions for us before we close out?
No, y'all are awesome.
All right.
Thank you.
Well, thank you guys. Y'all have a wonderful evening.
You
Thank
too.
you. Y'all have a good night.
Okay.